So today we're going to talk about surgical theory 1. So this is just for easy revision after intensive studying and learning. Okay, so let's start with matching contents, where you match the contents in column B with the contents in column C. So write answers in column A, and then there may be more than one match for each item. Select the item that best matches the term, and that was supposed to be term provided. Question 1. Concerning stages of fracture healing. So we have column A where you're supposed to be putting the answers. Then we also have column B where you're supposed to writing with your findings. Okay. So here what we are going to do is that for specifically this one, sorry, for specifically this one, I'm going to be writing in column A, like as the question has said. So the stages of fracture healing are used in mnemonic HIPCCR. But for the C, you have to know that callus formation starts first, then consolidation second. Okay, HIPCCR. So hematoma formation, inflammation, which is granulation tissue formation, then callus formation, then consolidation, then remodeling at the last stage. So here, what I'm talking about is that, so stage 1 is this one, then stage 2 is this one, stage 3 is this one, then stage 4 is this one, then stage 5 is this one. So in column A, we're going to say stage 3 is C. Okay, I think that's a bad one. Okay, C. I think at least that looks like a C. And then stage 5 is the last part, which is E. Okay, then stage 1 is A. Okay, is A. At least this one looks like A. And then stage 4 is D. Okay, then stage 2 is B. Okay, so that's my B. So that's HIPPCR. So stage 1, hematoma formation. Stage 2, granulation tissue formation, inflammation. Stage 3, callus formation. Stage 4, consolidation. Then stage 5, remodeling. Then that's all. Okay, so here the same concept, but this is regarding the Gastiero-Anderson classification of open tibia fractures. But now this classification is now for any open fracture. You can use it to classify an open fracture, the Gastiero-Anderson. So type 1, type 2, type 3, then type 3 you have type 3A, B, and C. Then column C, just 1 centimeter, B, no periosteal stripping, then C, and D, and E. Excuse. Okay, and then type 1. So type 1, we have a wound which is just 1 centimeter. So this is type 1. Type 1. Okay, let me write A this side. And then meaning this one, that's type 1. Then type 2, we have a wound which is more than 1 centimeter, but it is okay. For type 1, we have a wound which is less than 1 centimeter and there is mild contamination. Then type 2, we have a wound which is more than 1 centimeter. So this is type 2, wound more than 1 centimeter, and but this one 10 centimeter and there is mild contamination. So this is C. Then type 3, we have type 3A, B, C. So type 3A, we have a wound more than 10 centimeter. Then under type 3A, we have no periosteal stripping, so which is this one. Okay, that's B. So B. Okay, so this is B. Then type 3B, we have periosteal stripping, which is this one. So this is periosteal stripping. that's D. Then type 3C, we have neurovascular damage, which is E. So here, for you to remember, just know that type 1 don't just as 1 centimeter, type 2 or more than 1 centimeter but less than 10 centimeters, type 3 A, B, C. A, no periosteal stripping, B, periosteal stripping, C, neurovascular damage. Then question 3, same concept. So which statement in column C best describe the contents in column B? So this is where we now define the meaning of the terms. So here we have agency, intermittency, post-micturition, dribbling, and dysuria. Then column C we have A, we have this is A, we have pain passing urine, difficult passing urine, maintaining a stream, and difficult initiating a stream. So this is then delay stopping urination and failure to delay urination. So agency is so definition for agency is the failure to delay urination, which is E. So agency, that's E, that's agency. So agency, that's E, failure to delay urination. Then intermittency is delay initiating urination. So delay initiating urination, that's C. See, then post micturition dribbling, this is delay stopping urination. So this is this part, which is D. Okay, then dysuria. So dysuria is pain when passing urine. So dysuria can also be sometimes difficulties passing urine, but this is A is dysuria. So that's A. The dysuria part is there. And then for this part, part B, this part, I know it's confusing with dysuria, but dysuria is just difficulties or pain when passing urine, but difficulties passing urine and maintaining a stream is not dysuria. Difficulties passing urine and maintaining a stream is hesitancy. So that's hesitancy, the H, but it wasn't here. So let's just put hesitancy. Okay, that there was just imagine there was hesitancy there. That would be the answer. So H here. Then we are done here. Okay, go to another investigations in. So for this column, specifically, we have column C and investigations in column C and conditions in column B. So, and you have to bear in mind that there may be more than one match for each item. So urethral stricture. So for urethral stricture, we can do a urethrogram, which is the F. So this is the urethral stricture urethrogram. Then BPE, which is benign prostate enlargement. So for BPE, it's a rectal examination. And remember, rectal examination, that's D, it's BPE. And there is a common misconception where people, okay, I think this is a common practice now, especially in our setups, where if you do DRI, you find that the prostate is enlarged, then you go direct for hyperplasia, you say BPH. So BPH, that's a histopathological type of diagnosis, because even if you touch, you find that the prostate is enlarged, you can't say benign prostate hyperplasia, because that wasn't the hyperplasia you were touching, you're just touching enlargement. So clinical diagnosis BPE, histopathological BPH. That's the way it's normally supposed to be. Then CA prostate. For CA prostate, we can use PSA. Then if it's more than 10, then you know that okay, this one is high risk for CA prostate. So just E. Okay, that's E. Then CA bladder. So from the name, the bladder is cyst, cystoscopy and biopsy. That's B for CA bladder. That's B. Okay, then we are done here. So this column, we have which statement in column C best describe the contents of column B. And remember, there may be more than one match for each item. So select the best one which is provided. So benign prostate enlargement. So like I said earlier, it is a clinical DRI for the benign prostate enlargement. Clinical DRI. Then the blood outlet obstruction investigation of choice you can do is urodynamic, which is E. So okay, let me write. So this is D, this is E. Okay, imagine E. Okay, that's my bad E. Okay, then BPH, like I said, histopathological. So it's a common practice where people make a diagnosis of BPH, but that's not how it's supposed to be. It's a clinical diagnosis is BPE, and then BPH is a histopathological type of diagnosis because we can't palpate hyperplasia, but we can see it on the histopathology results. But clinically, it's a DRI. You find that there's benign prostate enlargement. Yeah. Then nocturia. So for nocturia, this is so nocturia for my guess, not for my guess, for my findings, nocturia I would put because the voiding symptoms which are caused by lower urinary tract obstruction, they include straw stream, uh, splitting or spraying, intermittency, hesitancy, straining, and terminal dribble. These are the signs of voiding, because I think most people would go for voiding symptom for nocturia, but me, I would go for frequency. I put F there because voiding symptoms are the ones I was mentioning, and there is no nocturia there, but that's under frequency. Okay, so we are done. Another column, so investigation in column C for condition in column B. So column B, appendicitis, intestinal obstruction, abdominal, and CA, esophageal. Then column C, first plain abdominal X-ray, esophagoscopy plus histology, clinical barrier meal. Okay, so for appendicitis, it is a clinical diagnosis. This is D. Okay, that looks like B. Okay, this is D. Okay, then intestinal obstruction. So IO, you do a plain abdominal X-ray. That's B. Okay, then abdominal trauma, you do a fast, which is A. And then for a CA esophageal, you do C, which is esophagoscopy histology. So that's C. So I think this was awesome. Okay, then this is another question. So a 34-year-old man came as a referral from Kapirimposhi Hospital, and they came with complaints of abdominal pain, fever for 1 day. So the vague periumbilical pain. So the vague periumbilical pain woke him up 12 hours previously. So, and he then developed anorexia, nausea, vomiting. Then the pain was severe such that the patient could not perform any activities. Then the pain, this is supposed to be pain. So the pain migrated to the right lower region and was worse while he was transported on an ambulance from Kapiri. So the patient's temperature was, so this was the patient's temperature. 38 degrees Celsius, and the pulse was normal. Okay, so the questions are: define acute abdomen. So, define acute abdomen. So, acute abdomen is a life-threatening condition that has. Okay, before I define, let me just read through the questions. Define acute abdomen. What is the most likely diagnosis? List 5 signs that could support your above diagnosis. Mention uh, surgical surgical causes and 5 surgical causes of an acute abdomen, or 5 surgical and 5 non-surgical. Okay, so that's what they want. Then outline your list of investigations and principles of management. Okay, so these are the questions. So I think you can go back. So define acute abdomen. So we are doing this. So acute abdomen is a life-threatening condition that has developed in a short period of time and has abdominal pain which needs surgical intervention. But remember, not all acute abdomen requires surgical intervention, but it has abdominal pain that which may need surgical intervention. Okay, the most likely diagnosis. So for this patient came in with abdominal pain and a fever for 1 day. Then they had a vague periumbilical pain which woke him up previously. Then the patient could not do any activities, and the pain was migrating from the right lower quadrant of the right side. Okay, and the west when he was being transported from the ambulance. So as you can see, and the patient also presented with anorexia, nausea, and vomiting. So this is acute appendicitis. So I'm going to say AP, acute appendicitis, not AP. Sorry, not AP, but acute appendicitis. Acute appendicitis. Then list 5 signs that support your above diagnosis. So for the 5 signs that support my above diagnosis, so they've okay. Let me again so they have the pain which is migrating from the right lower quadrant. That's 1. Then the fever 2, because the elevated temperature is 1. Then I don't know if they just wanted signs, because if I was to mention 5 signs alone, they won't be enough. So because I only have here, I have elevated temperature, I don't see any rebound tenderness here. But let me just mention and pick out the things which were positive for acute abdomen. So elevated temperature is a sign 1. Then when the patient was being moved, that also could be a sign, because movement causes pain in acute appendicitis. But these are the only signs you could see. But if you put even the symptoms such as nausea, vomiting, and the migrating of pain from the right iliac fossa pain, those ones, they could even make up to 5, because those are the signs from the above diagnosis. But the question again doesn't specify to could just these signs that would support our diagnosis from this scenario, or you could just mention any others. But if the case was to find out the ones which were they just the signs that would support our diagnosis, maybe not from the scenario we have been given. That's when maybe we can include the Sowa sign, obturator sign, pointing sign, Ovsing sign, Brambeck sign, Bodwig sign, those ones. But this one hasn't specified specifically what we should put. Then mention 5 surgical and 5 non-surgical causes of acute abdomen. So let's start with 5 surgical. So under 5 surgical, So 5 surgical. We can have an acute pancreatitis. We can have perforation of an ulcer. We can have cholecystitis, appendicitis, diverticulitis, mesenteric vesicular occlusion, little bowel disease, perforated bowel, any condition that can present with under the surgical causes. So those any causes of blunt abdominal trauma, could be a perforated viscous, like I said, and those are under surgical. And then non-surgical. So this is non-surgical. In under non-surgical, you can have ectopic pregnancy, most likely ruptured ectopic pregnancy, hydrosalpinx, salpingitis, myocardial infarction, acute pericarditis, acute hepatitis, pyelonephritis, gastroenteritis, decay. Those ones can present with an acute abdomen. Okay, and then list the investigations. So for the investigations, we can have laboratory and radiological. So for the diagnosis of acute appendicitis, we said it's clinical. So radiological, you can maybe just rule out any other perforation of a viscous. So you can just do a chest X-ray, and even though these other ones are expensive, but CT scan can be requested, but not as a regular basis, but just for investigation sake. Then under lab, we can do full blood count /DC, then ESR, CRP. You can also do U and E's. So those are some of the investigations. Your close match and grouping, those are some of the investigations you can do for this patient. Then principles of management. So this patient has presented with a high fever, so you give your antipyretic. They have pain, you are going to give your analgesia, can run fluids, can run your IV fluids. Then you can also on the investigations, like I said, you can do a scan as well on the laboratory. So instead of CT scan, you can do an ultrasound as well on the imaging. So let's go back to the principles of management. So those are the supportive ones. The supportive ones I mentioned: your antibiotic, analgesia, your fluid, and also your definitive, where you actually do a appendectomy. But again, that's the way you are supposed to write, because you separate your investigations, lab and radiological, then your principles. You begin from there, things which you can do before you arrive at your definitive. Okay, but we are done with the definitive. So go to question 8. So this is a 45-year-old. So 45-year-old lady reported to KCH with complaints of painless swelling in the right breast for 3 months. So the duration is 3 months, which was accidentally noticed while taking a bath. Specifically, the physical examination shows a lump on the right outer quadrant of the breast, 10 centimeter. So this is 10 centimeter in size. Add inconsistency with nipple retraction. Then there's a palpable axillary nodes noted. Then discrete and add inconsistency. Then the next question is saying, what is your diagnosis? List 6 factors that list 6 factors and mention other 5 signs of your diagnosis. 8 months. What is triple therapy? Then what are the methods of getting a biopsy? Okay, so let's go back and start with your diagnosis. So for this one, this is a breast CA. This looks like BRCA. Okay, just this is breast cancer. Then factors, list any 6 factors and mention other signs. Okay, for the risk factors, let's start with the risk factors. So risk factors for breast cancer can be classified as modifiable and non-modifiable. Then under non-modifiable, we have gender, which is more common in females. You can have age, postmenopausal. You can have early menarche, late menarche. You can have genetics, where there's family history. Those are some of the non-modifiable. Then under modifiable, you can have obesity and alcohol intake. Though you can also have use of estrogen-based contraceptive under modifiable, and also we have nulliparity. But sometimes if you go above 35, even if you modify it, there's nothing. So you have already been there has already been chronic exposure to estrogen. So nulliparity is also one of the risk factors. So we are done with the risk factors. The signs of the diagnosis. So on the signs, we can have purge orange, dimpling of the skin, retraction of nipple, ulceration, skin ulceration. So ulceration can be on the nipple, can be on the skin, and fungation. Then you can also put the 67 Ds of nipple changes. You can have nipple distraction, nipple duplication. So those are some of the signs you can get. So but specifically here they just wanted any other signs, so I think you've mentioned more. Okay, then what is triple assessment? So triple assessment, we have clinical, radiological, and histopathology or histology or pathological. So under histology we can have history and examination. Then under radiological we can have ultrasound and mammogram. And remember, ultrasound is more than 35, less than 30, 35, and then mammogram more than 35 because of the breast density, differences in breast density. Then under histology you can have, they are just wanted to mention what is triple assessment. So we are not going to get far with the storage because of this question, which is asking about the method of getting biopsy for breast cancer. So for under histopathology, that's where we have the methods of getting the biopsy. So we have fine needle aspiration and cytology. You can have core needle biopsy. You can have incisional biopsy. You can have excisional biopsy. Those are some of the methods of getting a biopsy. Then after the treatment modalities, we have mastectomy, lumpectomy, modified. We can have radical mastectomy, modified radical mastectomy. Those are some of the treatment modalities for this condition. Okay, then otherwise we are done with the surgery theory 1. We have more surgery theories which are coming on the way. Thank you for watching, and if you haven't subscribed, can subscribe and share this video to people who are sitting for their exams. Thank you.